And now for today's program, we're turning our attention to something truly critical, right? How does trauma affect your overall health across your entire life? We're going to be joined today by two members of the incredible Grady Trauma team, Doctors Abigail Lott and Vasiliki Michopoulos, who will walk us through what they do, how you can access emergency care, what it means to have trauma early in life, what you need to know about your past that's going to affect your future. In a nutshell, I think I got that right. Whatever you face a health crisis yourself, or someone that you care about, just these are great things to keep in mind. And today's session is going to give you some practical and potentially life enriching knowledge today. Let's go ahead and jump right in with Dr. Abigail Lott and Dr. Michopoulos, and we're going to see about trauma and its impact on health across the lifespan. Welcome to the show.
Awesome. Thank you so much, Emily. And thanks everyone for joining. It's an honor to be here and get to talk to everyone a little bit about something that happens, unfortunately, in many people's lives, and that is exposure to trauma or traumatic events and how that actually can impact health across the lifespan, not only mental health, but also physical health. I'm Dr. Vasiliki Michopoulos. I'm an associate professor in the Department of Psychiatry here at Emory. I've been here for over 15 years and have been really trying to understand the biology and the impacts of trauma on our health. And I'm joined today by my good friend and colleague, Dr. Abigail Lott. Abby, please introduce yourself.
Hi, everybody. Excited to um, share with you today and get a chance to chat a little bit. I am Abby Lott. I am also a professor here at Emory in the Department of Psychiatry and a psychologist by training. I study how trauma impacts our health across the lifespan and across generations. And then I also take that to translate it into behavioral health interventions that can be helpful for individuals who have experienced trauma to help them really thrive in the face of difficult life experiences. So we're not going to talk a lot about treatment today, but in the Q&A, happy to chat about any questions that people have. And our, we want to kind of set the stage, and hopefully most of you already understand this or have heard about trauma, right, and its effects before. But basically, we know, right, that most people have experienced trauma in their lifetime or will experience trauma in their lifetime. And these kinds of experiences, like physical or sexual assault, intimate partner violence, those have a wide-ranging effect on our health across our body systems. We know that the adverse health effects of trauma not only affect our mental health, right, but affect all of these different systems highlighted here: our central nervous system, cardiovascular system, reproductive system, endocrine system, etc. And despite this, we're really overall haven't studied this a lot in civilians, right? Sometimes people think about trauma, they think about military or veterans. And in fact, all of us are exposed to a lot of trauma, and it can have far-reaching effects. And so a lot of what we do is actually study trauma specifically in civilians. And because trauma impacts certain people more than others, we are particularly focused in on understanding how trauma contributes to health inequities in women as well as minoritized communities. So we're housed at Grady and do a lot of our research there as well as in the broader Atlanta community. So the Grady Trauma Project that Vass and I co-direct along with Dr. Jenny Stevens is the largest study of civilian trauma in the country. So this is a big project that's been around for over 15 years or over 20 years now, and is really focused on understanding how trauma gets under the skin to impact our bodies, our brains, our behavior, and translate that into treatments that can directly address health inequities. So we'll talk a little bit more about the many ways that trauma can impact health and well-being. Great question from somebody. So trauma could be defined in a lot of different ways, and I wanted to make sure we were all on the same page. So when I talk about trauma, there are, certainly many ways to define it. I like this definition by SAMHSA, which is basically that trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and has lasting adverse effects on an individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, in our world of psychiatry and psychology, right, we have very specific definitions of what counts as a trauma versus what doesn't. But we know that the things that are kind of sudden and come outside of the normal everyday experiences of life are often what we're thinking of when we're thinking of trauma, and that they have that impact that is long lasting. So examples of that could be, child abuse, childhood sexual or physical abuse, things like sexual assaults or physical assaults, witnessing violence, also things like car accidents, natural disasters, things that can happen that are not specific to kind of person-on-person violence as well. There are many reactions following trauma that occur, and Vas will talk a little bit more about those in a minute. But one of the ones that we study at the Grady Trauma Project and are particularly interested in is post-traumatic stress disorder, which is a disease that comes as a result of traumatic experience exposure. So you have to have a traumatic experience in order to go on to develop PTSD. And this is one of the common reactions that can happen. Most people don't go on to develop PTSD following a stressor, but as we'll talk about, some are at greater risk. And so it's important for us to understand those things. PTSD is characterized by a number of different components. So things like re-experiencing or having memories of the trauma again and again when they don't want to after the trauma is experienced, avoidance symptoms, things like avoiding people or places or even thoughts related to the traumatic experience. Individuals with PTSD have negative alterations in cognitions and mood, or their thinking and their mood. So things like feeling disconnected from others, having negative thoughts about themselves or the world around them, feeling like things are dangerous at all times. And then also alterations in arousal or reactivity. So you might be familiar with the idea of hyperreactivity, something where you're easily startled or jumpy and on edge because of past experiences. That's what we call kind of hyperarousal. And all of these symptoms, when you have PTSD, have to last at least a month for it to count as PTSD and cause significant impairment. So as I mentioned, we do a lot of our work over at Grady Health System in downtown Atlanta. And part of what we've been doing over the past 20 years is trying to characterize and understand the scope of trauma and its effects in individuals who have low socioeconomic resources, as well as are minoritized and often underrepresented in research. So what we've found over the past 2 decades is that we see very high levels of trauma exposure in individuals who utilize services at Grady, with the average number of different types of trauma being 4. So that means, remember those different types like sexual assault, intimate partner violence, witnessing violence, different kinds of traumas. And within that, many people experience multiple events within each type, if that makes sense. We also see extremely high rates of PTSD and depression in medical patients at Grady. You can see in this figure here that we actually see rates as high as almost 30% for PTSD, when the actual general population average for current PTSD is around 3.6%. Similarly, we see 50% rates for PTSD in the Grady patient population, whereas the national general population is 8.3%. So you can see these very high levels of trauma exposure. And similar, you can see these levels kind of in depression as well. Some of the things that are important to keep in mind for why we think this is the case is not only do we see a dose response effect where the more types of trauma you experience, the greater likelihood it is that you're going to have adverse mental health effects like PTSD and depression. But we also know that there's this interactive effect of other life experiences. So work from our team led by Dr. Yara McCowie has shown that kind of the combination of interpersonal trauma exposure and racial discrimination heightens risk for higher levels of PTSD symptoms. Similarly, we know from work led by Dr. Meghna Ravi on our team that the experience of poverty and having neighborhood poverty further kind of interacts with trauma exposure to predict PTSD symptoms. So these are some of the kind of reasons we're seeing this disparity in heightened levels of mental health symptoms following trauma exposure in our urban sample.
All right. So Abby spent some time setting the stage for how prevalent trauma exposure is and how it can impact risk for post-traumatic stress disorder or PTSD. Also highlighted that depression is very common following trauma exposure in people who experience it. One of the things I'd like everyone to take away with them today is the fact that trauma exposure impacts many different behavioral and mental health conditions. So PTSD and depression, which Abby went into in detail, but we also know that trauma exposure can increase risk for aggression and anger management challenges, can also lead to difficulties in maintaining relationships. We also know that trauma exposure is associated with shame or guilt and self-blame, as well as increasing risk for other self-destructive and high-risk behaviors, including increased risk for suicidality and also increased risk for engaging in substance use and misuse. And just here to show some data from our group that has been also replicated in many other studies looking at the effects of trauma, specifically on substance use. What we see generally is that greater levels of trauma exposure, which is here on the x-axis, is associated with greater reports of misusing alcohol, cocaine, opiates, and marijuana. So, trauma can have really robust psychological impacts, but importantly, it can also have very big impacts on our physical health as well. And so, in the literature, we know that trauma exposure has been associated with greater risk for suffering from chronic pain. We also know that trauma exposure can increase risk for negative reproductive health outcomes, specifically in females. We know that trauma can impact risk for preterm birth and preeclampsia and some of the other adverse birth outcomes that women can suffer from. There's a growing literature linking trauma exposure to greater risk for all sorts of different cancers. There's a very big literature on trauma increasing risk for adverse cardiovascular outcomes, heart attacks, mitochondrial infarctions, strokes. And then we also know that trauma can have long lasting effects on metabolic outcomes. So trauma has been associated with increased obesity, but also increased risk for developing metabolic syndrome or type 2 diabetes at some point in one's life. And this is just one highlighting one study, old study from GTP, essentially showing that individuals who meet for a current PTSD diagnosis have greater odds of also suffering from metabolic syndrome later on in life. A lot of the work that we've done at GTP is really trying to understand how trauma gets under the skin to really influence biology to drive this increased risk for adverse health outcomes. We're not going to talk a lot in detail about this, but I'm happy to answer any questions. We know, of course, that trauma can impact the brain, leads to development of PTSD and depression, like Abby introduced us to earlier. It does this by altering how the brain makes neurotransmitters and how those neurotransmitters are released. And then depending on the brain region that those changes occur, they can influence our symptoms and our behavior. And here on the right, I'm just showing one of the most well characterized and reproduced effects of trauma and PTSD on the brain is that we see.
Dr. Michopoulos, this is Dr. Parker. Can you explain what the amygdala does again, please? What is the amygdala in the brain? What does it do?
That's exactly where I was headed. So one of the biggest things that we see is that trauma and PTSD changes how the amygdala responds to threatening things in our environment. So the amygdala is it's highlighted here in the little yellow parts down here. And hopefully you guys can all see my mouse. Is kind of our fear network hub. It's very in tune with what's going on in the environment around us, and it responds to threats in our environment. And typically, the activity of the amygdala is modulated by higher order brain regions like the prefrontal cortex. So all this big mumbo jumbo up here. And so one thing that we see is that individuals with PTSD have amygdalas that are hyperreactive to threatening cues, threatening stimuli in their environment. And in parallel with that hyperactivity of the amygdala, we also see decreased ability of the prefrontal cortex to actually inhibit the activity of the amygdala. This hyperactivity and this lack of top-down inhibition of the amygdala by the prefrontal cortex really seems to be due to alterations in how the two systems talk to each other. And how the neurotransmitters that are regulating those brain regions are interacting with one another. So happy to answer more questions about that later. So, that's how trauma can really impact the brain to manifest as PTSD. We also know that trauma and living with PTSD can also have really long-lasting effects on other body systems. I touched a little bit about the reproductive axis. There's literature to support the notion that trauma exposure can affect how the endocrine system that regulates our reproductive physiology is altered. There's a big literature on how trauma can change how our body actually responds to subsequent stressors. If you look at activity of the two major stress systems in the body, that being the hypothalamic pituitary adrenal axis, trauma can dysregulate how this axis works, which can lead to either too low or too high levels of cortisol. Cortisol being, our primary steroid hormone that is an activator of the stress response. And then we also know that trauma can alter how our noradrenergic or our sympathetic nervous system responds to stress such that it's actually hyperactive. And so that is one of the mechanisms by which we know that trauma exposure and PTSD can actually increase risk for adverse cardiovascular outcomes. And then finally, I want to touch on another system that is dysregulated or impacted by trauma and PTSD, and that is our immune system. And so this is something that really has been gaining increased levels of evidence over the last, I would say, 20, 25 years, is that individuals who are exposed to trauma and individuals suffering from PTSD and depression also show increased inflammation in the periphery, and I happy to talk about it, but inflammation in the periphery really can have adverse effects on all the systems that we just talked about. We know increased inflammation can drive risk for cardiometabolic disorders. But some of the work that we've actually done at GTP also has linked this increased inflammation that we see in individuals exposed to high levels of trauma and living with post-traumatic stress disorder, that increased inflammation can also change brain function to drive symptoms of PTSD and depression. And so that's another take-home point I want to highlight here is that the brain, lives in the body and it pays attention to what's going in the body. And so, if there's increased inflammation in the periphery, that can impact the brain, just like increased inflammation can impact your heart and every other organ system. And the way by which this inflammation actually does this is by altering how neurotransmitters are made in the brain in the specific brain regions that we know are important for emotion. So happy I'm not going to get into much detail here, but that really is the take-home point of this slide. And just to highlight a little bit on one of the things that Abby touched on that we're really interested in our work at GTP is really trying to understand mechanisms that confer increased risk for PTSD, specifically in women. And so this is a result that has been reproduced in the literature. This image is from a meta-analysis, so a statistical approach used to summarize the literature that exists to date. And whether you look in overall samples of what's been published or specifically in studies looking at specific groups of people, that we see that women are on average twice as likely than men to suffer from PTSD. And so one of the mechanisms by which we think that risk may be confirmed specifically in women and females is the impact of hormones that are made by the ovaries over the course of the female lifespan. And it's important to note that these hormones are differentially, the levels of these hormones change over the female life course. And so what we know is that the sex difference in risk for PTSD emerges during adolescence and puberty. So this is the time where the reproductive axis kind of turns on. So the ovaries start producing estrogen and progesterone. The testes in males start producing testosterone. And really what we see is at this developmental time point is where that sex differences emerges when we're specifically talking about PTSD. Now, most of the work in this area has really been done during the main reproductive years of the female lifespan, looking at risk for increased PTSD symptoms or other psychiatric conditions over the course of the menstrual cycle in females. So 28-day menstrual cycle, where there are fluctuations in the levels of estradiol and progesterone that occur over that period. And typically what work shows is that periods of the menstrual cycle where levels of estrogen are low versus those that are high are the ones that are associated with greater risk for psychiatric disturbances and PTSD being one of those things. So though a lot of the current work is really looking at how the changes in these hormones actually are what are driving the increased risk for symptoms, specifically in females. Are there other really significant lifespan phases in the female lifespan, and one of those is pregnancy. And there actually hasn't been a lot of work done in this area. This is an area that I'm going to show you some preliminary data from. But pregnancy is, a very profound and biologically active part of the female lifespan. And we know that levels of estrogen and progesterone significantly increase from the first trimester of pregnancy to the third trimester of pregnancy and acutely drop in that postpartum period. And we really, no one's really asked the question of how pregnancy may actually increase or decrease risk for PTSD. And we think this is super important, not only for the mother, but also for the fetus that's developing in that mother. And then, of course, as we age, as females age, there's also perimenopause and the transition to menopause, where essentially you get a stopping of those, 28 days on average menstrual cycles. And perimenopause has been linked to greater risk for depression and PTSD, and for depression in women. But the mechanisms behind that is something that we're looking into. And then, of course, during the aging processes, females don't typically see those higher levels of estradiol and progesterone that they see during their main reproductive years. And so it's really unclear what being in that low level of hormone state for a long period of time is impacting health in general in females. So just to show some data, we just wrapped up a longitudinal study of trauma-exposed women to assess how PTSD symptoms change over the course of pregnancy. And what we actually found is that pregnancy seems to be conferring some resilience to PTSD in trauma-exposed women. So essentially, here on the X is week gestation, and here on the Y is total PTSD symptoms. And what these data are indicating is that individuals or people with higher levels of trauma exposure early on have the highest PTSD symptoms like we would expect, but over the course of pregnancy, these symptoms significantly decrease. And this is not specific to any specific subcluster of PTSD symptoms like Abby was talking about at the beginning. But interesting, what we find is that this decrease in symptoms is related to the increased levels of progesterone that we see during gestation. And this is super interesting because we know that progesterone has anti-anxiety effects. So typically, or the way that we're interpreting our results is that pregnancy is actually conferring some benefits to mental health, specifically in the context of PTSD as the pregnancy progresses. And then finally, just to show some data that I really think we were at the forefront of showing, as I mentioned earlier, that the perimenopause has also been associated with risk for increased mental health disturbances in females. Most of the work here has been done in depression. No one had actually looked in the context of PTSD about how perimenopause and the transition to menopause actually influences PTSD symptoms. And so in our large GTP data set, we were able to replicate other findings that show that perimenopausal women seem to have an exacerbation of depressive symptoms. We saw that similar effect when we looked at PTSD symptoms. So essentially, women of perimenopausal age had reporting significantly greater levels of PTSD symptoms than women in the premenopause or the postmenopause years. And so we're currently following up on this, doing a longitudinal study, just looking at mechanisms conferring this increased risk for PTSD during the perimenopause in women. And I know that was a lot. Thanks for hanging in there. And of course, all the work that we do at GTP wouldn't be possible with the community and our participants, and of course, our funders and our trainees and everybody. It really is a multidisciplinary team science research project, and happy to answer and take any questions.
Okay, great. There is a question in here. This one is from Emily. Can you talk about multiple traumas versus one trauma in a person's life and health outcomes? And it says healing trauma impact health later in life. And so when we talk about post-traumatic stress disorder, is it a series of traumas or is it a single trauma that can have an effect?
Abby, I'm gonna let you take this one.
Sure. Yeah. Great question. So any exposure to a trauma can result in PTSD. And we know that certain types of traumas are more likely to result in PTSD than others.
I'm sorry, I meant to mute myself.
Oh, that's okay.
I just
why did
kind
somebody
of
mute me while I was talking? Okay.
So we're talking about one event. Okay, I'm thinking about let's say women who have experienced a single early childhood trauma, say the death of a loved one. For example, gunshot accident to childhood, one single event
Yep.
versus childhood abuse over years.
Right. So it's going to depend on both severity of the exposure as well as other risk or protective factors in an individual's life. So we know, for example, sexual abuse and sexual assault have a substantially higher risk of development of PTSD than other traumas. To your point, Dr. Parker, about this single incident where someone was killed absolutely could result in PTSD. And part of it is going to depend on, were they there? Did they witness it? Did they have direct exposure to the event itself? That can increase the risk. The presence of, kind of a warm and supportive home environment and a safe, kind of stable home in childhood can be a protective factor that may make it less likely for someone to develop PTSD. But in general, we see those interpersonal traumas are going to increase the risk of PTSD development. Things that are experienced by like yourself, right? So a sexual trauma, sexual assault, and severity of what happens. However, we also know that so an individual can definitely develop a trauma just after having one traumatic exposure. However, we know there's a dose response effect as well on PTSD and other mental health outcomes. So the more traumas somebody experiences, the more likely they are to develop PTSD. That's that sort of dose response. So many traumas can sort of add up together to make it more likely that they're going to have PTSD symptoms. And it's possible also to, I work closely with the Trauma Recovery Center and the Grady Emergency Department, and we see, right, people that come in for a new trauma. Well, they may not actually have PTSD from that new trauma, but instead have had PTSD since childhood related to another trauma. And so you can develop PTSD symptoms from new traumas as well as have them sticking around. But to Emily's other element of the question, one thing that's really important to remember is just because you have trauma doesn't mean that all these bad things are going to happen to you either. And it is possible that, there's lots of things that are protective and can help build resilience in the face of trauma. And treating PTSD, treating other mental health symptoms that come up as a result of trauma can absolutely take away some of the damage that gets done at that biological level that Vas was talking about in terms of reducing your risk for future adverse health outcomes.
So as a follow-up to that one, Mrs. Nunez has a question about, can seeing someone die cause PTSD or depression that affect the brain permanently? You talked about having a strong supportive family environment being something that confers some resilience. This is kind of along that line. Is your brain affected permanently by a single event? I'm not exactly sure how I can quantify that a little bit better, but it makes sense. I was like, our previous question was, is one trauma enough to induce PTSD versus serial traumas? And then it's depression? Is this a permanent effect? I guess that's the thing, is evidence or having witnessed traumas once, twice, or whatever, does this cause permanent brain damage? I think that's the question.
Yeah, so one thing to keep in mind is absolutely experiencing certain types of trauma can result in changes in the brain, and those changes aren't automatically or necessarily bad on their own. And we have to kind of look at the big picture and know that treatment or treating symptoms can also be helpful in altering brain function as well, right? So we know that certain behavioral health treatments or taking an antidepressant, right, can alter those neurotransmitters and how those work as well. And so it's not that it's going to be permanently problematic and your brain isn't going to function right again. It's that we see these changes and we know that that can result in problems. Additionally, understanding what's going on for you and getting the right support can kind of take back some of those negative effects as well. I'll give a quick example that, we know that exposure to a lot of community violence and negative experiences with violence in children can alter how their brain works, but it doesn't necessarily mean that it results in long-term problems. It could be that it results in more focused attention on certain things, right? And so understanding how that works just helps us better determine what kind of support someone may need. I don't know if there's anything else you'd add, Bess.
I'm having troubles with the buttons. I'm sorry, I muted you again. I was just gonna to highlight Abby's point that, using evidence-based treatments to help reduce the burden of PTSD, there is a literature that supports that, treating your PTSD is also going to benefit other systems in the body. Like, for instance, inflammation. If you treat your PTSD, there's some reports that your inflammation in the periphery is going to go down. So, you know, treating these mental health conditions that can arise from trauma exposure can indeed have really robust benefits on body systems post that intervention period.
Okay. There's a question on the Q&A side that says, can you add more to the information about how police violence affecting individuals' PTSD incidents, particularly among African Americans? What is the work that's been done there, and what correlations have been found between directly police violence toward African Americans? Is there anything that you can add to what we know about or what we don't know? What do we know, actually?
Abby, you want to take this one? I was going to go back and see I can't remember if the IRRS measure breaks that apart.
Yeah, so certainly, as I mentioned before, we know that experiences of racial stress and discrimination kind of exacerbate the other stressors that are going on in an individual's lives to increase risk for mental health problems like PTSD. Specific to police brutality, right? So obviously, directly witnessing police brutality can absolutely, be a trauma that occurs both for the individual that's experiencing that as well as people that are witnessing it. In general, we know that kind of witnessing things directly have a stronger likelihood of PTSD development than indirect exposure. So things like watching things on television or seeing the news like through social media is going to be much less likely to result in PTSD specifically, but that doesn't mean that it's not harmful and impactful on the mental health of African Americans who are witnessing that, right? And it also can result in symptoms that sort of show up to be similar to PTSD. We see a lot of hypervigilance, right? And understandable mistrust and stress in terms of thinking of how not only how individuals experience the world and interact with people around them, but also, concerns about their kids and how their kids are going to be treated, what might happen. So there are lots of good studies showing all of the adverse effects when we think about in terms of PTSD in particular. We're going to, again, it still comes back to that sort of more direct versus indirect in terms of the likelihood of PTSD. However, we know that in general, sort of our definitions of trauma, which is, as I talked about at the beginning, kind of the entry point even to get into a diagnosis of PTSD, can sometimes miss certain experiences with racial trauma. And so there's actually a large movement and kind of a lot of work being done in that area right now to better improve the ways that we ask about racial trauma and ensure that those are, getting well captured and included, and much more being done right now to understand that more vicarious and indirect exposure through things like social media and stuff like that. But there's hopefully that gives you kind of a general sense of what's out there at this time.
The Grady Trauma Project, if I understood correctly, concentrates on women of color. And you specifically pointed out African Americans, but what about women who aren't necessarily African Americans? At Grady, I'm imagining you have quite a few refugees and immigrant females. Are you studying that population as well? In my clinical practice, I see women from other countries, and they're by design, I guess, or have developed quite a few traumas. And I'm seeing lots of anxiety and lots of depression in that particular population. Are you also focusing on women from other countries who may be legal or illegal immigrants to this country?
Yeah, great question. So just to clarify, it sort of depends on the study in terms of who we do really emphasize women's health, so do a lot of studies focused on women. However, we also study kind of all genders and look at other outcomes. Like I have a PTSD and alcohol use study going on right now that includes women and men. To your other question about including more immigrants and other individuals from other countries. Absolutely. We just generally speaking from the way that we do recruitment and, contacting folks who have medical appointments and things like that, we get a predominantly African-American sample at Grady, but it doesn't mean that other people are necessarily excluded from some of our studies. We also had a study specifically looking at adverse childhood experiences in Hispanic caregivers and moms. And so it sort of depends a little bit on the specific research question of the study, but many of our projects have been broader and so include all individuals.
As well as men, right? I'm
Yes.
thinking about immigrant men because in this day and age, we don't want to leave anybody out. And I think that that's important. So thank you, Dr. Lott and Dr. Michopoulos. We really enjoyed your chat and your willingness to be flexible and come on first. So I think there's some information in the chat about your being able to contact Dr. Lott and Dr. Michopoulos. Can somebody put that up or put it in the chat, please? I thought I saw it a little minute ago. And lastly, we're going to end with our exercise with John Lewis, who's going to come on at the end. Again, I'm looking for Dr. Michopoulos and Dr. Lott's information about the study.
Yes. Do you ladies have it? Can you share it in the chat for anyone that would like to participate in your studies or your coordinators? So ladies and gentlemen, they're going to share that information in the chat, and we will also include that in the post BrainTalk live correspondence that will go out to you all. So
thank you. Thank you, Dr. Lott. Thank you, Dr. Michopoulos.
Great presentation, ladies.
On with John. Can't hear him. There we are, Grady Trauma Project. That's what I needed. Okay, GradyTraumaProject.com. GradyTraumaProject.com for people who are interested in looking at more of the studies that these two ladies have, I won't say curated, created to better understand the effects of trauma and the brain. Okay. Okay, to refer yourself to a research study, you can go to refer to GTPA, Grady Trauma Project, right? GTP. How clever. Okay, that looks like we've got it, and I guess we won't see John today. So everybody take your 10 minutes and do something, do a breathing exercise or something. We'll see you next week on Brain Talk Live, and hopefully we'll hear more from the Grady Trauma Project throughout the year. Thank you.